Good evening, everyone. My name is Dr. Patricia Watts Kelly, and I'm the Associate Dean of Research and Scholarship at the College of Nursing at the University of New Mexico. Welcome to this 7th speaker series. This is our 7th rendition of our speaker series this evening, and we're very fortunate to have Dr. Van Roper and Dr. Jan Martin with us this evening. I would like to go over a few housekeeping items with you all this evening. We ask you to mute your microphone. For the best viewing experience, please set your Zoom to speaker view. There will be 30 minutes of questions and answers at the end of the presentation. Please keep your questions till the end and put them in the chat box. Regarding the continuing education, UNM College of Nursing is an approved provider of nursing continuing professional development by the New Mexico Nurses Association and accredited by the American Nurses Credentialing Commission on Accreditation. To receive your certificate of completion for 1.5 contact hours, you must sign into the Zoom chat with your name and credentials, stay for the entire activity, and complete the post-activity evaluation by the 6th of September at 5 p.m. You will receive your certificate by mail no later than 2 weeks after September the 6th. You will the PDF attached to the Zoom chat provides you with the link for the post-activity evaluation, and we will include the link directly in the chat. Our goal for this learning outcomes for tonight are, upon completion of this program, you will be able to define remote patient monitoring, explain advantages of remote patient monitoring in chronic disease management, identify challenges in opinions for remote patient options, for remote patient monitoring, and utilize basic and easily available tools for remote monitoring of chronically ill patients in low resource settings. We have with us, as I mentioned, Dr. Van Roper and Dr. Jan Martin. They're clinical professors at the College of Nursing. Dr. Roper is a family nurse practitioner with over 20 years of clinical expertise, and Dr. Martin has over 30 years of clinical management and leadership experience. And I would like to thank Dr. Martin for spending one of her last days prior to retirement with us this evening to enlighten us on chronic disease management. And without further ado, I would like to hand this series over to Dr. Roper and Dr. Martin. Thank you.
Hi there, everybody. Let's see, we're going to get the slide presentation up here in just a second. While Dr. Roper's getting that up, and we are informally known as the Van and Jan Show, which we've done in various venues. But in order to talk about this particular grant effort, I need to say just a little bit about the couple of years before it that contributed to the shaping of this and our passion around this topic. So back around, I think it was 2018 or so, Dr. Roper and I started looking at telehealth. We were concerned that there's so little of it in the state, and with access issues being what they are, the rural nature of the state being so diverse and broad, we were trying to figure out ways to promote the adoption of telehealth in various entities, big system and low resource settings like the FQHC, Federally Qualified Health Center environment in the state. And what we started investigating in 2018 around remote patient monitoring, which we'll go into in more depth during the slides, is it's very costly right? I mean, it can cost an organization hundreds and hundreds of thousands of dollars a year plus in implementing, very resource heavy sometimes in implementing. We looked at a whole bunch of different vendors, interviewed with several of them. Dr. Roper in particular did a lot of the technology work around that. That is not my expertise. So that was kind of where we were, but we couldn't find too many folks who wanted to play because of the expense, because of the resource heavy nature of it. So, you know, we just kind of kept plodding along, and you can go to the next slide, Van. And then oh, we have no disclosures. Okay, we do not. Here are the objectives, and then I'll go back to where I was. We will define remote patient monitoring, explain the advantages of remote patient monitoring, otherwise known as RPM, in chronic disease management, identify challenges of and options for remote patient monitoring, and utilize basic and easily available equipment in the management of chronically ill patients in low resource settings. So the other population that we've done a lot of work around, and a lot of listening to voices on the ground, both from patients and folks in community and from clinics, particularly community clinics, is, you know, we understand that seniors have a lot of issues around chronic disease, issues of isolation, difficulty accessing care and other resources that are even more severe than some of the other vulnerable populations in the state. And we're at a time when our senior demographic is increasing at one of the fastest rates ever in New Mexico. So this was an issue before 2020. Next slide, please. Did you want to speak to this one, Van?
Yeah, I'll be happy to do that. Part of what has prompted all this, obviously, was the pandemic that we've been living through. Where we are in that particular point now, I'm not really too sure. The biggest thing that we saw here happened back March 11th of 2020, when the World Health Organization declared that COVID-19 was a global pandemic. As healthcare was monitoring the maps of where the virus was located, the Center for Medicare and Medicaid Services expanded the availability of services by reimbursing providers for telemedicine provided care a few days prior to the global pandemic being announced. The change in the access to telehealth services opened up the doors for us as clinicians and licensed healthcare providers to offer virtual visits to all of our patients, which kind of led to what we'll eventually get to with the remote patient monitoring bit. And then as the pandemic evolved and progressed, telemedicine services were being utilized for close monitoring of patients who were sick with the COVID-19, but were not sick enough necessarily to require hospitalization. And we're just now starting to dig back through all of this data to start to look at what it is that's going on in terms of how remote patient monitoring has impacted patients, and looking at this as a viable option first as we move forward in primary care with this new balance of telehealth and along with our usual traditional practice that we typically have. As this has been a vital way for treating the patients here in the US healthcare system, and it continues to push the point of implosion since the SARS-CoV-2 or COVID-19 virus has exposed these greatest weaknesses that we had in our system. So by utilizing the telehealth, this assists in mitigating this highly transmittable and ever-evolving virus as each variant varies in severity of illness, with asymptomatic disease to mortality. And we will probably continue to see that with what might occur here in the fall and into the winter. Some key benefits that we've noticed from telehealth and assisting in this COVID-19 is a rapid change in healthcare in the United States. Strains on the hospital system continue to be at times overwhelmed emergency rooms and urgent care, to decrease bed availability, decrease supplies, and hospital staffing shortages. So in order to assist with these increasing challenges on a global pandemic level within hospital systems, we needed to have innovative but safe ways of monitoring patients at home, and for us to have some good development along those lines. And so here, just to cover that, you know what exactly remote patient monitoring is. It's considered a type of telehealth as opposed to maybe something specifically on its own. It's a method of healthcare delivery that uses the latest advances in information technology to gather patient data outside of the traditional healthcare setting. And we found that we can use this for both acute and chronic management. So to kind of move the clock to what it was that motivated us to get involved into this, we move here into where it started. So Dr. Martin.
Okay, so you can go to the next slide. March 2020, right? So as I was saying before, we were unable to engage partners in an active way to dive into the bigger type models of telehealth that involve major vendors where everything's integrated into the electronic health record because it's so big and it's so cumbersome. Right. So at the time of COVID, there was maybe 5-6% of all healthcare in the state that was utilizing telehealth. That was it. And there was an effort, at least under Health and Human Services for Medicaid, to increase that to 12%. That's kind of where we were when COVID hit us. So there was this instant impact to primary care practice. I mean, it was instant. Went from a culture of packing in as many patients as possible in a clinic day to all of a sudden, literally from one day to the next day, to keeping as many patients out of the clinic as possible. And that was to manage patient safety, employee safety, because as you all remember, people were getting sick, and also to preserve PPE because there wasn't enough. I'm sure there are those of you who remember that blood on the sidewalk that are on the front lines. So there were shortages of masks, there were shortages of gowns. We didn't know exactly what to do. How do we keep our clinic rooms, exam rooms clean? What do we do with our waiting rooms? I mean, it was a lot of unknowns in those first even 2 to 3 months. Most of the New Mexico federally qualified health centers, which I'll call FQHCs going forward, they feared closure. El Pueblo had 3 months of operating revenue at the rate that they had to reduce. They had to reduce by 80%. So only 20% of their usual day were patients that were actually being seen face to face. And that was an immediate change. It was the same with all the other FQHCs around. So they were looking in a very dire way at maybe 3 to 4 months of operating revenue at a time when everybody needed them more than ever. There were 6 clinics, FQHCs around the state that did close their services right away, most of them temporarily. One was permanently closed, I believe. So I got a call, Sunday, March 15th, right after the emergency order, the public health order. I got a call from the executive director at El Pueblo. We need telehealth right now. Really glad, really sad I had not listened to you guys a year ago when you wanted to implement it here. What can we do now? So I called Van, Sunday afternoon, and of course Van answers right away. And Monday, he and I met with the executive director out at El Pueblo, Ricadeso. And, like I said, he's faced with 80% visit reduction volume. So next slide, please. Day 2. Zoom for Healthcare, which Dr. Roper had just been investigating, HIPAA compliant. We chose that platform and got the first provider up and trained by the next day, by that Tuesday. This is a provider who had been out of state during the declaration, had just returned on that Sunday, that 15th, and by requirement of the governor would have had to stay home in isolation, right? Just because she had been traveling from out of state, meaning she wouldn't have been able to see her patients. This was a behavioral health provider who also happens to be faculty at the College of Nursing. But got her up on the platform, and by day 3, she was seeing patients. So, in the first 2 days, first providers trained. Next slide, please. Day 4, all 10 clinic providers were trained and had system access. on Zoom for healthcare. And Van will talk about the technology of these things after a bit. We had to develop very suddenly processes for scheduling and reimbursement, right? These weren't things that had been done before. How do you schedule someone when they're not actually coming into the clinic? Primarily, the initial visits were phone with just a few video calls, right? Reimbursement for phone visits, phone-only visits, really didn't happen until a couple of months later. So the first phone visits that were being delivered were mostly free of charge. So it didn't help sustainability of the clinic at all, but at least it was a way for patient access. We were able to positively increase the number of visits, but like I said, didn't have much of an impact on the revenue cycle yet. Next slide, please. So the survivability is still a question, right? Even when phone visits did become revenue generating, at first anyway, it was still very, very low volume, low dollars. There was a difference between Medicare and Medicaid commercial. I mean, it was all over the map. Nobody followed the same rules. So while we were able to at least talk with patients and connect with them via phone, it was still very limited effectiveness overall and a short-term fix, definitely not a long-term fix. The feds started signing the 1135 waivers. These are some of the waivers that allowed for reimbursement of phone visits. It opened up previous restrictions on different types of telehealth visits that previous to these waivers was not very effective for a clinic. It really was still very limited. And some of these restrictions or the waivers are still in place that have opened things up. So in just a quick plug going forward, we need to continue to advocate to keep these structures open so that clinics can use telehealth in a survivable way. We wrote several grants to support telehealth, clinic capacity, budget gaps. Some of them were funded, some of them weren't, but we did get a bunch of money for the clinic to support some of this work. Next slide, please. So then April and May 2020, this is where Dr. Roper and I put together, well, he put in the ECHO content, which had been stuff that he'd been researching for quite a while, which Van will talk about. But we did this for the entire FQHC network in the state through the New Mexico Primary Care Association, because everybody was having the same issues, but nobody had clear guidance. Everybody had a different creative way of dealing with it. It was all over the map. Everything from how do we deal with things within the clinic, both clinic structure and infrastructure. How do we deal with keeping patients safe? How do we deal with spotty and absent internet and patients with no technology equipment, right? So everyone had different strategies for dealing with this. So this was kind of an open forum ECHO that where we just shared what we were doing, what worked, what didn't work, and shared a lot of that throughout the entire state. Because for the entire network, the FQHC network, they were all operating at 70% or more reduction in their patient volume with COVID, the impact of COVID. Let's see, it was widely attended by clinic providers, by staff, by their leadership. We had all sorts of folks in these sessions. We looked at a variety of inexpensive telehealth applications. Some of these folks, because again, rapid implementation, right? Some of these folks were doing clinic visits via FaceTime. Well, we know that's not HIPAA compliant. They were using everything from Skype to Google Meeting to all sorts of platforms. You know, obviously they were going to be very, very short term and some of them a little bit sketchy. Okay, I'll just be honest. Since there were inexpensive HIPAA platforms available, it's like, why not go with just HIPAA from the get-go? So The Zoom for Healthcare kind of emerged for a while, and then others were using things like Doximity and some others, which we'll talk more about. By May of 2020, 100% of our statewide FQHC network, which is 15 different organizations and probably over 100 separate clinic facilities, had some type of functioning and reimbursement telehealth. That's pretty remarkable, I think, compared to the 5% or less in March. Next slide. Van, you want to talk about this slide? It's your work.
Yeah, this was just some statewide recognition for us having got this up and running. We had 3,500 remote patient visits within a very short period of time as of June, and that's just 3 months into it. And at this particular point, I'm not really too sure what our number is now, because we were continuing a fairly
it's at 70% now.
Yeah. So, yeah, but that's all that was.
So initially the phone visits, it really didn't impact the budget at all. But as we started doing more video for telehealth, and phone visits became reimbursable, even though it was a small amount still, budget levels improved to about 80% of pre-COVID levels. Now, this was just by June. So again, this is just 3 months in. We went from a deficit of 70 to 80% in budget or more, because for some clinics it was a lot higher, to about 80% of pre-COVID levels. 70% of visits were telehealth visits, with an increasing percentage of televideo. In June, El Pueblo had 75 new clinic patients, which was higher than even their pre-COVID levels for new patients. So we began to have to look at, in this time, not just the technology and the skill set and the infrastructure or processes for the actual patient visit, but all the pieces that have to happen beforehand. Like, for example, the consent. Patient consent had always been done in-house, right? With the patient wet signing a document. And this was true not just for El Pueblo, but pretty much across the network. Very few had any kind of e-consent processes. So we needed an acceptable e-consent process so that we could actually admit new patients to the clinic without having them to physically come into the building. So there was that part. Then some treatment orders require clinical metrics. For example, if you've got a patient who's having trouble breathing and they're not on oxygen, to get them on oxygen, particularly if they're Medicare patients, you have to send a pulse ox reading. So it doesn't really make sense to have them physically come into a clinic, risk their own safety and the safety of all the employees to do a pulse ox, right? Or same thing with renewal, like there's annual renewals for Medicare, right? For oxygen. So why have them physically come into the space? I mean, there were all these considerations that it's not that we didn't give thought to them before, but now we had to figure out a different strategy for them. So we started thinking about the clinical metrics. What about blood pressures? Where are people going for blood pressures, right? They either come to their clinic or they go while they're waiting online for their pharmacy and they do a self-check blood pressure in Walgreens. Well, that wasn't happening anymore. People were getting mail order drugs, right? Or home delivery drugs, because Walgreens didn't want them in-house either. All of this was going on. And these are the venues where particularly seniors, I mean, it's not exclusive to seniors, but particularly seniors manage their chronic illnesses, right? And all of a sudden, folks are really isolated at home, more afraid than ever, and having to figure out creative ways to be more resilient in how they access any of their health care. So it was a challenge. let's see. Oh, and then also ongoing provider and staff shortages exacerbated by isolation and quarantine requirements, right? Every time there was an exposure, your staff was out or your provider was out, or their kid was sick, right? So all of a sudden they can't come into work even though they're not sick. So if we're able to do telehealth with them from home, then we don't have to risk the clinic. We can still keep our visit volumes up. You see where I'm going with that. So this is all by June. This is just a few months in. Next slide, please. So now we're at September, month 6, and El Pueblo's visit volumes continue to increase and now have actually exceeded our pre-COVID total monthly visits. In September, we had 82 new patients, which also exceeded pre-pandemic, and telehealth increased to 75% of total clinic visits. So there was only 25% of volume that actually occurred either in-house or in parking lot, which I'll talk a little bit more about. The billing experience was still pretty unequal. Medicare, Medicaid, in-person rates were better than telehealth until it took a good 6 to 8 months to really have that stabilize more in the FQHC world, different in the non-FQHC world. Reimbursement rates are different and processes of contracting are different. Commercial payers continue throughout and still are poor and very inconsistent in how they reimburse. This is an issue for us in healthcare. And in primary care especially. Medicaid and Medicare reimbursement is still temporary because it's based on those CMS 1135 waivers, which are based on the public health emergency order. And as all of that starts to change as we move forward in the next couple of years, if they go back to pre-pandemic restrictions, it's going to reduce our ability to do telehealth once again. So that's something we all, I think, need to keep alert to. Primary care is going to be dependent on high volume telehealth for the foreseeable future, especially in this state. Next slide, please. So funding, okay, so this is the supplement that we're going to talk about in more detail. This is an NIH administrative supplement that came up through the CTSC. I think it was in May we wrote for it. And this is the COVID-19 just in time, because we were hoping rapid implementation, rural telehealth implementation in FQHC primary care network. And let's see, then there's the health center program. Yes, the American Rescue Plan. This is federal funding for lookalikes, which has kept a lot. There are over 100 lookalikes in the country still. It's kept us open because the lookalikes do not get the federal funding that the full-fledged FQHCs get. So you're really dependent on your direct patient volume for that. Next slide, please. You want to do this one, Van?
Sure, glad to. So finally here we have a table of data. I don't know if you've got a smaller screen, it might be a little difficult to see this. From January through July of 2020 and 2021, showing you some comparison here. Note that there were no telehealth visits in January and February of 2020. We started telehealth in the middle of March with 26% of our total visits being telehealth that month. However, by April of 2020, we were at 68% of our visits at telehealth. We currently have, last numbers I'd been exposed to, about 30% of our visits. Sounds like, Jan, you were saying perhaps maybe as much as 70.
Yeah, at least as of last month.
Yeah. The numbers seem to change fairly rapidly.
They do change.
Right. And we're expecting as the fall approaches, particularly with this increase in some of the Omicron variants that we're seeing right now, that we're going to have an upswing in the number of telehealth visits probably once again this fall. I hope we don't. It's difficult to predict, but it's a good possibility. But I think this time we'll be ready for it because we have had the implementation put in place here. And so here, Dr. Martin, you want to?
Oh, yeah. This is voices from the ground, right? So this is patients. This is from through the echo, different things that we've learned about what the actual experience is and has been. So there continue in New Mexico, and I'm talking about the state. In New Mexico, there continues to be significant disparities regarding access to the internet, and for some, access to actual phones. So I don't know if there's anyone on this video that remembers the Obama phone. It was a real thing. So during the Obama era, there was a period of time of a couple of years where, and this was primarily for Medicaid patients, I believe, where folks who didn't have phones were able to get a flip phone. Well, a flip phone doesn't work real well when you're trying to do telehealth. I mean, you can do just a regular phone visit, but you can't do a video visit, right? And the Obama phones are only good for so many minutes a month, which families tend to go through pretty quickly, and then they no longer have access to phone because they've used up their minutes for the month. So it's not a huge number of folks out there, but it is still a thing that exists that limits access to pretty much any kind of care. Let's see. So clinic and patient creativity writ large. I mean, this is like, you know, how do we strengthen resilience overnight? And this was, I'm just talking March and April right now. So there were patients who had to use temporary hotspots to have access for telehealth visits. So some of these clinics were providing hotspots to patients. We did get some funding for some hotspots, but the whole administration of some of this stuff, you know, some grantors want to get the equipment back at the end of the grant, and you know, there's just all sorts of weird barriers that come up around trying to get funding for things like hotspots and phones and internet. Some you can, some you can't. A lot of the pueblos, they were on physical lockdown. I mean, I'm talking about bars across the road. You could not exit or enter some of the pueblos, particularly in Sandoval County, without express permission from the governor of that pueblo, including emergency services. So call the ambulance because I have to go to the hospital real quick. Oh, let me get permission from the governor first. This is what some pueblos were working under for quite a long period of time. So, you know, like a lot of the kids who were now being homeschooled, right? So Santo Domingo Pueblo, for example, limited access to internet. So where do the kids go to do their homeschooling? So these are some things that in the state, we are going to have to be particularly aware of the impact over the years to come of these years. It's not just the obvious ones. The school-based health centers, they were effectively shut to primary care and behavioral health when the schools closed. Maybe you have access to telehealth, but how does a kid do a confidential service inside their home and feel comfortable talking to the provider on the phone? Sometimes there were folks that would go sit in their yard to do a confidential call, or they'd go sit in their car to do a confidential call. Had a patient, there was one patient, it was a provider that was telling me had a patient was sitting in the closet to do her confidential call because she didn't want her husband to overhear. So all kinds of impacts that we wouldn't necessarily think of first of mind are having an impact. Not just COVID immunization, because that wasn't available yet, But all other immunizations, our immunization rates have gone way down. I think they're coming back up, but it's a challenge. Let's see, so I talked about that. And does anyone even know? And then, as a constant thread throughout is this significantly reduced access to how do we get ongoing and intermittent clinical measures for acute and chronic disease management? How do we get the blood pressure? How do we do oximetry? How do we do weight management? Diabetes management. So also emerging throughout this is that once folks experience telehealth, some patients were actually expressing feeling more engaged with their provider than they had before. They felt that they were more accessible to them. They felt a little bit more in control of some aspects of their, and then I talked about the clinic staff catching on too. So we started to think about new opportunities that COVID would bring, not just the barriers. Next slide. So kind of the next stage, like I said, when phone and video alone just aren't enough, right? All those clinical measures that we can't get by digital because we don't have the big expensive remote patient monitoring where everything's integrated and you got nifty tools at home where you can take a temperature or a blood pressure, those, and send it digitally in. We didn't have those. So the CMS definition is federal definition. So for Medicare and Medicaid, collection of physiologic data digitally stored and or transmitted by the patient or caregiver. So that is a really big emerging trend, particularly driven by big corporate health entities because it's expensive and it's resource heavy. And the FQHC networks in particularly are low resource settings. Most of them don't even have an RN. They have a few providers, they have a few front office folk, and they have a few MAs. That's what a lot of these clinics survive with. So they don't have their own IT, for example, or some of these other resources that are needed if you're going to have the high-end digital integrated systems, which granted are state of the art, but not always often not financially feasible. High cost. And accessible for only very limited populations. It's usually the high-risk hospitalization patients, high risk for ER, those things that are going to cost a system greatly would be the population that gets access to this, to the high-end digital resources, right? Because of the cost. So our alternative option was a low-tech digital home assessment kit. And our thoughts around that were thermometer because, we're doing COVID checks with temperature, right? If you don't have a thermometer, how can you do that? Oximeter, automatic blood pressure cuff, weight scale, even some, low-end exercise equipment, resistive bands, stuff like that were what we were using. But these four things primarily were the kit. Commonly available. You can go out onto Amazon, except when we had the shortage and you couldn't get oximeters anywhere for a while. Generally broadly available, and they're inexpensive. For under $100, we provided these things, or could budget these things. And it enables key clinical parameters without bringing the patient into the clinic space as often. And then we started thinking, could this be an opportunity to advance the patient's own engagement with their own chronic care self-management? And it could be implemented in a rapid way. So rapid cycle implementation was possible. Next slide, please.
Now, I might just add here the piece about the equipment. Some of the challenges were exactly like what Dr. Martin was saying here, that the scale of resources that were available for the stocking was at times extraordinarily difficult. But it was amazing how little this cost compared to, say, like some of the more high-tech pieces of equipment we had. one of the things we investigated very early on, and I have to admit it's my favorite toy that I don't use, is the TytoCare, which is this wonderful device that you can use that hooks up to your smartphone. You can look in ears, throats, you can listen to hearts, you can take temperature with it. You've got a high definition camera all installed into it. And the difficult thing about this, so we spent some time negotiating with them and then also in collaboration with Washington State University on pursuing the use of this, both for patient use and for training. And to give you an idea of the cost of this, the startup for 50 patients with these devices was $75,000. And you have a monthly fee for access to the software. You have a different type of hardware you use to interface with it within your clinic, which just made it grossly prohibitive from the standpoint of the vast majority of small clinics or rural health facilities or most privately owned 1 or 2 provider clinics. So in spite of the fact that I'd love to take it over to STEMI and have somebody over there figure out how to hack the thing so I could use it more simplistically without all the software, it was really presented quite a challenge. And that's what backed us into looking at what my mother affectionately calls Walmart medicine, because it's as inexpensive as we can get it and anybody can go pick it up, where we found that we could find these machines. And in fact, some of the comments that we got with that even the less expensive machines that we ended up getting for people to use worked better than older machines people had that were as much as a year or 2 older, in fact. So a very fascinating process to go through trying to determine what pieces of equipment that we could use in the process of moving ahead with this. And I'll pick this slide up here. One of the things we wanted to talk about that everyone would want to be aware of is what some of the benefits are for using remote patient monitoring. Reduced hospitalizations, for instance, are something that we've seen with this. Statistically, there's shorter hospital stays as the patient can be discharged with the remote monitoring device, and that crosses over a variety of different disease processes, not just necessarily COVID. For us to be able to monitor the patient at home. It also tends to lower the number of emergency room visits that patients encounter. We definitely saw that within our patient population during the pandemic thus far. We had better health outcome for our patients, particularly those that were in remote areas. For the most part, we could usually get in. If we didn't have Wi-Fi, we could at least get in with cellular service so that we could talk to patients. And if they had enough bandwidth for us to pull it off, we could occasionally do video, although that in and of itself was awkward. We find that there's better preventive management for chronic conditions with this. Patients are oftentimes much more engaged with their health care. And we'll see a little bit later here in another couple of slides for our small project that we did, some of the comments that patients made that reinforced their feelings about being able to see numbers and understanding what that meant for their diabetes or their blood pressure or anything along that line. It also reduced the risk of COVID exposure along with other illnesses for patients and their healthcare providers. So for the most part, other than a couple of snafus where family members popped in to see grandma and were positive, we actually had pretty good experience with patients not being as exposed and had a better understanding of how to protect themselves. So some of the challenges that we looked at with this, and these crossover into other types of telehealth other than just remote patient monitoring, was implementation and staff training. For instance, one of the difficulties we found early on, and it was in the literature and part of what we were trying to stay sensitive to in our implementation processes, is that if your front office staff, who are the people who are talking to the patients, don't feel confident about the technology, then that can be an inhibitor right there off the bat. So completely by accident, we ended up taking one of the front schedulers that we had at the clinic and did a video visit with her, with one person in the lunchroom and another person in the exam room, and they got to see how that worked, and they became very excited about it. And so that seeded that same process amongst the other staffing that we had there that were interacting with patients. So when they talked to the patient, they had a genuine excitement for this new technology and even had the capacity for at least some low-level low literacy types of issues for people to be able to learn how to use their phone at a basic level. Sometimes it required a higher level of technological knowledge to be able to assist a patient with an issue. But oftentimes this ability for front office person to say, oh, all you have to do on your iPhone, your Huawei phone, your Google phone, whatever it is that you've got, you just got to do this and that'll get you on. And oftentimes that's all that we needed. And we saw a definite uptick in people being scheduled for particularly video visits at that time. So the patient technology barriers oftentimes can be issues with that. And some of that has to do with just feeling intimidated with this new technology. They're holding it in their hands, this access to the entire globe through the internet. And oftentimes all they're doing is sharing pictures or maybe texting and calling on the phone back and forth with each other. And that's pretty much the extent of it. When we get to the some of the responses we had in our survey for our little project, we'll talk a little bit about that too. We also had found that it was pretty time consuming for both patients and staff. So patients oftentimes in particular thought it was too much of a pain for them to do it. And sometimes time went by and they weren't able to access healthcare. And then they came back and said, I really need to be in contact with my provider, show me how to do this. And that was kind of unfortunate. Somebody has to go through that experience to get there, but that occurred. And then we also had to kind of weed through who it was we were seeing. We had to look at our capacity, what it is that we could and couldn't do. And we sort of learned on the fly with this, but there were some things we thought we couldn't do by video that we actually could, that we learned about. And that informed us as to what patients we could actually monitor and where we had to draw the line and say, I'm sorry, we can't do this. You're going to have to go to either urgent care or to emergency, or you're going to have to do something else. Maybe we need to schedule you for a clinical visit where you come in here and we see you on a scale where the patient's protected in such a way that we don't go through and expose the other staff and potentially reduce our staff in the clinic or even shut us down for a period of time. And then it also gave us an idea too of people with higher need. Do we need to get those devices to them so that we're able to better monitor them and help reassure them these are components of better healthcare for them by introducing them to this low level technology. So we'll roll now into the remote patient monitoring pilot study that we did. This was a small study that ran. I just closed this from December 2020 to August of 2022. We had 20 patients that we initially took into the study in this single FQHC lookalike effort. We had greater ambitions, but time, physical constraints, access to equipment really limited us quite a bit. But what we ended up doing to help the other FQHCs around the state and the lookalikes was to work with Eileen and the New Mexico Primary Care Association and did the tech support for starting up telehealth in your clinic. So that was the way we were able to reach out to other clinics, but we were able to contain our pilot here to just a small clinic where we had a better idea of what we could potentially see and hopefully could develop some research patterns and some work patterns in this that we can move to a larger scale. So our first aim was to assess the effectiveness of the addition of the home assessment kit that we built. All of this came out from Amazon on the ability to clinically manage patients at home during the COVID-19 pandemic as compared to requiring an in-clinic visit. And then two, we wanted to characterize the changes in clinical productivity and workflow utilizing telehealth visit strategies as compared to pre-COVID-19 non-telehealth visits. So in a lot of ways, what it was that we did get, you saw the numbers up front that Dr. Martin talked about, that we actually made some pretty good progress with this. So why these patients? We had participants in the EPHS Complex Chronic Care Management Program, Medicare, and 2 or more chronic illnesses of moderate to high risk. And then we also added in RN case management into this, so it blended in with some other funding that we had in order for us to be most efficient and utilize our resources as best as we could. Our systems were all in crisis. Our in-person visits were very tightly restricted for safety of the patients and employees for the foreseeable future. And one of the things that we learned that now seems like perhaps common sense for some of us that have worked in this is that if you have your entire staff together in a clinic and you are potentially exposing yourself to, in this particular case, COVID-19. If the exposure comes in and then we find out later, essentially we had to shut the whole clinic down. So what we ended up doing is we split and ran a skeleton staff of both in-person patient providers as well as support staff. And that way, if something happened, we only took out a portion of our staff, and then another crew could come in after the facility had been cleaned, and they could operate it the next day. So that really saved us quite a bit by doing that particular strategy within our clinic. Even pharmacies and grocery stores that routinely check where people are able to go check their blood pressure. There was a lot of fears about people being around other people, about touching equipment that might have been contaminated with COVID-19. Some of those types of facilities severely limited the number of people who could come into their facility to begin with, which tended to push people away to start with. So we were really finding this growing population of people that needed closer monitoring, but were hesitant for a variety of different reasons. And so we had to investigate it and why the remote patient monitoring was so essential. The clinic population are among the highest risk and most vulnerable to complication and access barriers in this particular clinic. We have about 40% of our population is considered rural. The others are often low income, some without insurance. We have sliding scale. We also have a pretty high level of Medicare, Medicaid patients in our patient panels. The data supports the value of patient engagement and self-management of their chronic diseases. We know this from the Healthy People 2020. And so we wanted to embrace that when we started to think about what we could do to come out with a feasible, executable remote patient monitoring. And we realized that if we could go with the lower tech equipment in there, it would require less training for the patient to use that. Bathroom scale doesn't require quite as much training for someone to use than, say, like the TytoCare device that we had that takes a little bit of fairly moderate to significant technology literacy to be able to use it. So we looked at chronic disease management, and then looked at the patient, their access to even just a basic phone, and then looked at the capability that we might be able to have to, the patient might be able to have for them to use the equipment. So that's where we moved into this. So this is all preliminary data. Apologies to admin, I didn't go strictly and have a week of vacation like I was supposed to. I spent some time looking at our responses that we got back. There were basically three tools. We had a entry into service, we had a mid participation, and then an end participation set of surveys for these people. Two people dropped out because they felt that they got what they needed out of it. Plus they got to keep the equipment in the middle of this. So that was the only thing that happened. In that case, I have not had the time to crunch this into any sort of analytical software yet. So this is basically just looking at things like responses that we had back at this particular point, and I'll have more detailed analysis of this as we continue processing the data on it. So we had 15 of our participants were greater than 65 years old. We had one that was 45 to 54, and then one that was actually had one with no response. So there should be two people from 45 to 54. Male, we had 6 and 11 female, and one that preferred not to answer out of this. We had one particular form that wasn't completely filled out, and my guess is that our one of our participant researchers there that were taking the data in probably didn't finish that out. As far as willing to use telehealth, 100% of the participants felt very confident with this. They felt like they had better access to their provider. We had 4 of them that saw some cost savings in it, some of it having to do with transportation, some of it with copay. There was time savings and convenience with that. And several people commented they got faster service because they were able to access the telehealth services more quickly than they were to be able to come in and get a visit. We only had 4 people who admitted that they had used telehealth before. We had 8 people who said they had used phone apps previously, and we had 8 that had not used their phone. And then if you ever delayed talking with your NP, PA, doctor, nurse about a healthcare problem, we had 8 that said yes and 10 that said no. And then as far as whoever used a mobile phone apps before, we had 6 of them had said yes, but these were for non-health related activity. So we didn't really have anyone who had experienced telehealth before using mobile phone apps. Any problems with using equipment? Nobody had any issue with that. And to show you what we used in this particular study, we had electronic thermometers, we had a bathroom scale, with one person commenting they had a difficulty standing on it, but it was for physical reasons. They had issues with that as opposed to a problem with the device. We had 11 with pulse oximeters and blood pressure cuff. We had 17 of those. Did this make it easier to work with the provider on your telehealth visit? We had 100% yes in response to this. Reasons for this included easier access to their numbers, which they one of the really nice benefits of this, because they were able to relate things like how I feel with my blood pressure or my blood glucose or my pulse oximetry, what have you. People were felt much more engaged and had better communication with the nurse that was working with them as well as their provider. They liked the fact that they had better data to better understand their disease and then to be able to comment and discuss this with the provider that was working with them. Quicker access, more aware of how they're doing overall. So it made them more attuned to what their body was doing, in spite of the fact they may not necessarily be feeling bad. And they liked the fact that they could share this with their home health nurse that was coming to see them, both from our clinical facility as well as some of them had home health care people who would come in to see them or contact them. Did it make you feel better that you could better participate in your visit? Yep, because they could keep track of their vitals. There were no in-person appointments that were available, so this is part of what helped them keep up to date with their overall status. They were more informed about it. They were really liked the fact they could share this information with their providers and felt like their communications they were having back and forth with the providers were more thorough as a result of that. When they called the clinic, they could be more specific about what it was they needed. They knew what was going on and they could follow the trends themselves. So again, there are more elements in here of people feeling more engaged in their healthcare. Did they feel this made it easier to work with their provider in a telehealth visit? 100% of them said yes, because they felt like they could discuss more fluently with their provider what was going on. They felt more involved, and then they also felt like that access to care that were more available to them at any given time, as opposed to having to wait to come in and do a visit to get measurements and try to figure out what was going on. So there was a growing correlation between, if my numbers are bad, I can address something before I start to feel bad. So you saw a little bit of that came up in that. Does the equipment help you feel you could better participate in your telehealth visit? Yep. Objective data, ability to communicate with the nurse by phone if they felt bad. So there was that added element of another person that was involved in it too. Are you willing to continue using telehealth? 100% of them said yes. So we had the vast majority of them said better access to care, faster service, and then time savings and convenience. There was also some cost savings, as I mentioned earlier, information to the provider, and just better overall management and being able to follow their trends. And then what was it they'd be willing to use telehealth for prescription renewals? That was a fairly common one, as well as chronic disease management, follow-up for surgery or hospital follow-up. So some of these patients were perhaps diagnosed with COVID, for instance, in the hospital, still are having some pulmonary issues, for instance, and were able to be monitored at home. And they felt like that this was a nice way for them to be able to feel more confident in how they were feeling, where they were going in their overall care by doing this. Urgent care, a lot of people were really wanted to continue using either mental health or having access to mental health as a result of the telehealth access, and they felt better prepared. The one person didn't drive, so that saved them from having to get a ride and then being worried about whether or not the person might be positive with COVID. And then overall, a handful of people felt better because they were at home while they were being seen. So additional input that we saw in this: what did you like about participating in the program? They got help with their diabetes, understood it better. They liked interacting with the team. Getting help seemed to be easier. They felt closer and confident, and they felt like they had pretty decent equipment, particularly compared to what they had had in the past. And then some of the things that they were asking for us is, what changes would you recommend There was about 25–30% of the people said they would have liked to have had Wi-Fi, even though they still had access to us through their phone. A couple of people thought it'd be nice to have a smartphone where they had a little bit more technology that had access to apps where they could monitor some of their health indices a little bit better. Some people wanted more equipment. We even had someone who asked for a heating pad for her shoulder, and then internet access, which is not always necessarily Wi-Fi. Sometimes it's cost of service that keeps people from being able to access the internet. So there was people who requested that, and I believe one person even asked to have more treats. So that pretty much covers what we have gotten so far in this. Like I said, I'll do a detailed, more academic analysis of this once we get to a little more time to finish crunching the data on this. So, Dr. Martin, do you have anything else that you would like to add to what where we are at this point?
You know, I think it just briefly, it's about the creativity and the passion for patients that I saw across the FQHC network through this time. It's like we didn't have the option of saying no. No would have meant closing the doors, which would have meant ending those services in a lot of those communities, right? Because some of these communities only have a small clinic. And the resilience and the creativity in the face of things that we just automatically have said no to for so many years. No, we can't do, no, we can't do, no, we can't do because of X, Y, Z, right? All of a sudden we had to look at the ABC opportunities. And just an example about the internet, because we know like there's spotty places, there are not just spotty, there are huge swaths of communities across the state that have no internet access. But these folks in these clinics, I mean, they were calling local radio stations to put a bus with internet service in their parking lot on X days, so that patients could drive into whatever lot it was and do a video call from their car because the bus was there that day, right? Or there were different organizations that were doing similar kinds of resources where they would, at a very small community level, bring in some of those resources so that patients in that community could have access to internet. The Pueblos did some stuff like that too. It was really very inspiring for me, who can be jaded sometimes by large system. Not a judgment, it's just an is. So that kind of creativity and resilience was incredibly exciting for me to witness and to engage with. Eileen Good, I don't know if you have anything else to add to this, and I hate to put you on the spot, but if you do, you know, as the ED for the Primary Care Association, it was a joy. It really was. I mean, it was scary as heck, but it was a joy.
Jan, you and Van were just amazing. You are quite the duo, and you were there, ready to jump in, ready to try things, ready to do the echo for our providers, and just such a wealth of knowledge and understanding, and the work around the remote patient monitoring is so critical. So thank you for this feedback on what's been happening with that, and just thank you for all you've done. I'm going to retire too, so maybe we'll do something together in the future.
Absolutely.
But I sure do appreciate this work. Thank you all so much.
Thank you. I mean, it was just incredible to witness how folks, and these are communities that the majority of times we look at as lacking because they're small, maybe they're diverse, maybe there's a lot of poverty, there's a lot of chronic illness, there's a lot of those kinds of things. So we tend to look at them as from a need-based lens, right? But what we saw in this process was, in the coming together of folks in these small communities, they really built upon and strengthened the assets that they bring. And it wasn't, I mean, it was hard won, and it really stretched everybody's brain cells. But the assets that I saw, the strength of that in these communities really stood out for me.
Yeah, I would agree with that as well. There were even reports of creative things like some of the clinics opened up their Wi-Fi access so that people could pull in the parking lot and use their Wi-Fi at the clinic, and the provider would be at their personal home.
Right.
Little things like that you hadn't thought of, or even things like having a skeleton staff where a patient came into the clinic, went and sat in an exam room after somebody checked them in, and the provider might be talking to them on a laptop in the exam room as well. I mean, there was this sort of, we thought more about, let's see what we can do about getting the patient access to us remotely, when sometimes it actually worked better to flip it around the other way, to have the provider remote and then the patient was close by. And like you were mentioning, there were some community centers. There were, I don't know if any of this happened in New Mexico, but for instance, in some places, they even had a mobile clinic that would just be there for screening, that would have a hotspot available, and patients were then able to schedule through the people that were doing the screening with a provider who was remote to the mobile clinic, in order to be able to have a visit with somebody on a telehealth into things. So I mean, I think the whole concept of remote patient monitoring needs to have a permanent place in this. There's still, I mean, we still have some growing pains within our own clinical environment. And how do we manage those patients that are most complex, particularly if there is technical literacy is certainly an issue, health literacy is certainly an issue. And for some patients, just the ability, there's a gray line in there. I don't think it's very wide, of what people are actually able to do self-care with the assistance of telehealth and remote patient monitoring, versus this is somebody who really needs somebody in person in their home to be able to help them. So that's the line we're I think trying to define right now, and the way our circumstances are now in clinic. And hopefully we can be more attuned to that when, if and when that becomes an issue that we have to lean into that heavier and have a larger number of patients who are monitoring remotely rather than in person, as we're gradually moving into a little bit more in person now.
Great. Thank you, Dr. Roper. Thank you, Dr. Martin. Appreciate your presentation and sharing all of your experience with that. We're at the Q&A portion of our presentation. Before we do so, I just wanted to first thank Eileen Goody, same for all of her facts that she sent out on the chat. If you have a chance to read through them, she had some great figures on there as well that supplemented the presentation. I want to go ahead. We had a couple of questions happening while you were speaking, so I want to address those first. So we had Tammy Ledoux, who said, do we know the impact of COVID on nurse managed healthcare clinics, and were they included in the access to telehealth?
That question is related to nurse managed clinics that are not FQHCs.
Thank you.
Well, that's not directly part of what we've done in the FQHC network, but can you say a little bit more about how that might be different? Or
these nurse managed clinics are not do not have funding available through the federal government. They're usually through like nursing schools, et cetera, and stuff like that. That was the reason I was asking.
Yes, exactly. And it's a really great question. So I know that there are some in the state. I don't know how many are left, because it is very hard to manage those clinics. I have done that for the college, and so has Van. The funding, I will say that some of the funding that occurred federally in 2020 opened up to not just the FQHC and the FQHC lookalike networks, but broadly. So they would have been they would have had more funding available to them than what pre-COVID would have been available to them. Whether or not they accessed or even knew about it, I'm not sure.
Thank you.
Sure.
Okay, and Dr. Schimmels, I'm going to read your question. Forgive me if I say any of this incorrectly. Have you done any RPM with mental health outcomes, regular assessment scales like PHQ 2-2/9 or GAD 2/7 or suicide risk assessment specific scale, or looking at sleep using their own smart devices or others?
Sounds like you'd like to do a research project with us, Dr. Schimmels. I think that would be
Sounds good
very
to me.
fascinating. Yeah, because the clinic is one that has a lot of telehealth visits that we use, and that would be a very good project for us to work on to do that. Love the idea, but I don't have any metrics on that right now.
The Dr. Schimmels, the PHQ-9 is what El Pueblo uses as their HRSA measure, which I can tell you from having looked at it a week or so ago, I don't remember what the actual percent is, but it's way down, which is true across the network. And that would be a great one to work on. I mean, not that the others aren't important, but the PHQ-9 particular, well, the 2 and the 9 are measures that we look at El Pueblo.
Great. And if there are other questions at this point, you're welcome to put it in the chat or raise your hand virtually and we'll call on you. Kathy Lopez Bushnell says, thank you for the exciting work and hope it expands. Do you think this will improve healthcare with the patient collecting much of their data?
Hi, Kathy. It's, I don't think it's in the collection of the data. I think it's in the engagement of self-managing their chronic illnesses. And it speaks to the value that a lot of the self-management programs have, particularly around different chronic illnesses, because they're engaged with it, they're aware of it, and they have a stronger voice with their provider in their management. So I think it's more in those pieces than just in the passive collection of the data, if that makes sense.
And Dr. Kelly says, did you receive funding for this work?
Yeah, we did. And that was in slide number 15. So that was for the NIH administrative supplements with the CTSC. And then we also got monies from the 2021 American Rescue Plan funding for lookalikes.
Right. And most of that funding, while the administrative supplement was a $25,000 one-time, 1 year funding, and that was primarily for the home assessment kits and a little bit of Dr. Roper's time. The American Rescue Act funding was more robust and over 2 years.
Do we have any other questions? All right, well, I want to say thank you again to Dr. Roper and Dr. Martin for your expertise in this and sharing your information with all of us. Once again, I want to remind everybody to please sign in if you're expecting, if you want some CEs, so with your name and your credentials in the chat. We also need you to fill out the link to our survey by September 6th if you would like to receive CEs, and I'm putting that link in the chat as well. If for some reason you think of a question or you'd like to get in contact with Dr. Roper or Dr. Martin, actually, I don't know if you'll still have this email in a few days, Dr. Martin, but I'm going to share it either way. You're on mute.
There might be a brief glip, lapse in it, but then yes, I will be on it. So.
Okay, fantastic.
If you get a bounce back, you can send it to me. I could run her down.
I was going to say we'll find her. She's not going to go far.
All right. The Van and Jan show isn't done yet.
No, I didn't think so. So again, if you want to get a hold of him, you can do so that way. I want to thank everybody for attending the UNM College of Nursing Research Speaker Series. Please be sure to visit our website for our next one as it becomes available. I hope everyone here has a wonderful evening and be safe.